Hello, and welcome to this session on managing malnutrition. My name is Aditi Medalia, and I'm a registered dietitian and the Junior Medical Affairs Manager for Nutritious UK and Ireland Adult Portfolio. In this session, we will be exploring the definition and impact of malnutrition, how it can be identified and addressed, and the critical role of medical nutrition in supporting your patients in their treatment or recovery journey. In this session, we will also highlight how nutrition can support you in delivering better nutritional care in your practice. Let's begin by defining malnutrition. So, malnutrition refers to a state where a deficiency or imbalance of nutrients, such as energy, protein, vitamins, or minerals, leads to negative effects on body composition, physical function, and clinical outcomes. NICE further defines malnutrition based on the clinical indicators shown here, such as a BMI below 18.5, minimal or no food intake for more than 5 days, or poor nutrient absorption. Clinically, this criteria helps to identify those who may require urgent nutritional intervention. Malnutrition typically develops through 3 main mechanisms. First being reduced intake, and this is often due to issues like pain or dysphagia, whereby a patient can experience difficulty swallowing or loss of appetite. Secondly, increased nutritional requirements, and this can be caused by factors like infection, healing wounds, or the symptoms of conditions such as COPD, for example, that can lead to increased energy expenditure from the patient's laboured breathing, or the metabolic effects, especially the catabolic effect, of illness or tumours. And third being excess losses. And this can occur through things such as malabsorption, vomiting, diarrhea, or wound exudates. Malnutrition affects a broad range of patients. In England alone, 2.9 million people are affected by disease-related malnutrition. Groups at higher risk include recently discharged patients, older adults in care homes, those with chronic conditions such as the previously mentioned example of COPD, individuals undergoing cancer treatment, and those in rehabilitation or palliative care. It's important here to consider those mechanisms in the previous slide in the wider context. So consider social malnutrition. This is caused by factors like physical or mental isolation or financial hardship. This can coexist with disease-related malnutrition. For example, your patient may have increased requirements as a result of their condition, but the added layer of social isolation can fuel that malnutrition further. And crucially, although we won't be going into depth here, malnutrition isn't limited to those underweight. Those living with obesity can also be malnourished, especially when experiencing that key factor of unexplained weight loss. Left unaddressed, malnutrition sets off a chain reaction of adverse outcomes that can include increased falls, delayed wound healing, reduced muscle strength, higher complication rates, and even increased mortality. This underscores the vital role that community multidisciplinary teams play in identifying and managing malnutrition early across a variety of healthcare settings. Malnutrition also carries a significant economic burden, one that is around £22.6 billion annually, with around £15 million per primary care network. To help put this figure into context, that's more than the £4.2 billion spent annually on conditions related to obesity. Now, managing a malnourished patient can cost 3 to 4 times more than a well-nourished one, and therefore investing in and treating malnutrition is actually more cost-effective than not treating it. Through improving nutritional status and clinical outcomes, This in turn reduces healthcare use and the associated healthcare costs that can come with that. So how exactly do we manage malnutrition? Managing malnutrition involves a four-step process. First is identification, where we use nutrition screening to recognise those at risk. Second is assessment, so understanding the cause of and factors surrounding intake through discussions with your patient can help you to understand the true extent of malnutrition. And third is understanding the extent of malnutrition can help with your management plan. From there, you can set mutual goals with your patient and develop a plan to optimize nutritional intake. And finally, as with any treatment plan, monitoring, reviewing your patient's plan and progress and adjusting as necessary. We'll now look a little closer at how these steps can be practically implemented in everyday care. So, step 1, identifying malnutrition. For those unfamiliar, the Malnutrition Universal Screening Tool, also known as the MUST, was developed and validated by the British Association for Parenteral and Enteral Nutrition, or more commonly known as BAPEN. It's a trusted, effective, and widely used tool for identifying individuals who are malnourished or at risk of malnutrition. The MUST screening tool involves a simple, straightforward three-step process, often using information that's already readily available to you. So step 1 is utilising the patient's BMI, which can be gathered from previous notes in your system or patient-reported values. Step 2 uses the patient's weight history to determine the percentage of weight loss. Again, this can be accessed through past medical history or patient-reported values. Step 3 is an acute illness score. Through gathering additional information through your history taking and past medical history of the patient, if they are acutely ill or have likely to have had little to no intake within 5 or more days, that adds another point. The outcome is a score that will reflect the overall risk of malnutrition, 0 being low risk, 1 being medium risk, and 2 or more indicating the individual is at high risk. Screening should be conducted opportunistically during the first contact within a new care setting, such as upon registration with a practice, an outpatient appointment, or admission to a hospital or care setting. Screening should also be performed upon clinical concern. Examples of clinical concern include unplanned weight loss, changes in appearance, signs of muscle wasting, including in those who are deemed obese, reduced physical function, and more. Additionally, screening should be done amongst high-risk groups, such as those with acute or chronic diseases, individuals undergoing prehabilitation or rehabilitation, and socially isolated individuals who may otherwise be overlooked. Outside of the MUST tool, to support the practice of this, the malnutrition pathway has been developed and endorsed by 10 professional bodies within the clinical space. A community-specific pathway is also available to guide the integration of screening, monitoring, and use of oral nutritional supplements in practice, including when and how to discontinue them. This is a brilliant resource to assist you in identifying and managing malnutrition. On to step 2. For all individuals who are malnourished or at risk, it's important to consider the underlying cause to help identify the most appropriate nutritional care. Remember that some treatments and medications can have side effects which can impact eating and drinking, and therefore your patient's nutritional status. With the shift from in-person to virtual or telephone appointments, it's important to acknowledge that you may not always have the most up-to-date clinical picture. You can use patient-reported values for weight and height to calculate steps 1 and 2 of the MUST tool if available. If these measures aren't available, though, subjective assessments can help to inform a clinical impression of the patient's malnutrition risk. It's really important here that within those 10 minutes or so that you have with a patient, you are asking the right questions. As you already may do in clinic, the questions you ask for weight loss could also be used to screen for malnutrition, and it's imperative here that you use those moments for malnutrition too. Consider incorporating questions about energy levels and changes in GI symptoms into your conversations, and asking questions in appetite, clothes, and jewellery, as this can indicate for weight loss. For example, if a patient mentions struggling with swallowing, it opens up an opportunity to discuss how it's affected their eating and drinking. Consider psychosocial assessment as part of your investigation, so looking for those social malnutrition clues rather than just looking for organic causes. Identifying the causes and symptoms which are interfering with the ability to eat and drink, and addressing factors that can be reversed or modified should be an integral component of the treatment plan. Essentially, weight loss might be a red flag for underlying pathology, but it's crucial at this stage that we treat the nutritional impact of this, as well as make a referral for further clinical investigation. Once we determine the risk, our intervention begins. Management of malnutrition should be in line with the level of malnutrition risk, and the next step is intervention based on this risk level. For most patients, dietary advice and food fortification come first, but where food intake is insufficient or unlikely to meet needs, oral nutritional supplements should be considered. Guidance from credible bodies such as NICE, ESPEN, which is the European Society for Clinical Nutrition and Metabolism, and BAPN, the sort of British equivalent discussed earlier, supports the use of medical nutrition for patients at nutritional risk. Numerous clinical guidelines from NICE, ESPEN, and BAPN, for example, will support the use of medical nutrition for patients identified as being at risk. This can be useful to support your evidence-based practice when it comes to intervening with malnutrition. But what exactly is medical nutrition? Medical nutrition is a term that encompasses oral nutritional supplements, enteral tube feeding, and parenteral nutrition. As we saw from the guidelines previously, early and appropriate initiation of medical nutrition benefits patients. ONS, classified as foods for special medical purposes, play an important role in managing malnutrition, and the use of ONS is crucial as an effective strategy for managing malnutrition. Whilst you may be familiar with food-based strategies like dietary advice and food fortification, these are more suitable for medium-risk individuals. ONS should be immediately considered for those at high risk, so those with a must score of 2 or more. ONS can come in the form of powders, ready-to-drink milkshakes, puddings, and more. And we have a needs-based portfolio here at Nutricia, which we will touch on later. And we offer different styles to meet individual needs and preferences. And again, to support your evidence-based practice, NICE CG32 recommends considering oral nutrition support to improve nutritional intake for people who can swallow safely and aren't malnourished or at risk of malnutrition. ONS has been evidenced to not only increase nutritional intake, but to improve weight and function, assess through strength or quality of life, and reduce clinical complications, for example, like those discussed earlier, such as pressure ulcers, risk of infection, and hospital admissions or readmissions. Setting realistic, person-centered goals is a key part of managing malnutrition. Consider the stage of disease and treatment being administered. The table provides examples of goals across various medical conditions to guide your intervention. The goals listed may be those expressed by your patient or their caregiver. As an example, your patient may express their desire to improve their mobility and get stronger. So tailoring your intervention to help them achieve these goals is very important. It's also important to view malnutrition within the larger clinical picture. For instance, individuals who are frail or living with cancer often experience changes in body composition due to the breakdown of fat and muscle. Recognizing this common factor is essential for providing appropriate nutrition support. Patients with malnutrition tend to consume less food, leading to lower intake of protein and other nutrients, increasing their likelihood of deficiencies. Understand that the disease and treatments can cause physiological changes that suppress appetite, reduce your patient's desire to eat, trigger early satiety, affect their taste, and alter metabolism, impacting their overall body composition. In certain cases, consider ONS earlier in the management pathway to prevent unnecessary deterioration, especially in specific patient groups. Assess the progression of the disease, whether curative or palliative, to determine the level of intervention required and manage expectations for those realistic and achievable outcomes. When selecting an ONS, patient preference is paramount. Ensuring the supplement meets clinical needs and is acceptable to the patient will improve adherence and outcomes. As mentioned previously, food fortification and dietary advice is usually the first step for those who are more of a lower or medium risk. But when looking for the right ONS for those higher risk patients, you may be referring to your local formulary. Products are typically grouped into first line, second line, and third line options. Many products under the first line category are likely to be shake-style products, and these are typically considered low costs. These will also be high in calories with a standard amount of protein, so around that 12 grams of protein mark, and are recommended to be made up with milk. For some, these can be self-purchased in supermarkets, pharmacies, and online. And it's important to note that not all powdered supplements contain a full range of vitamins and minerals. At Nutricia, we have our version of this under the brand Complan. This is a high-energy, high-volume powdered supplement. With powdered nutritional supplements, it's important to consider the clinical appropriateness for your individual patient. Is the nutritional content sufficient enough for the needs of your patient? Will your patient be able to tolerate the volume of this? Does their physical status prevent them to appropriately make up the supplement? And also, it's crucial to consider your patient's social and occupational factors and how it may influence their intake. For example, do they have access to resources such as a fridge, fresh milk, or storage? If when reflecting on these questions there are concerns in respect to your patient, then a ready-to-drink supplement may be more appropriate. This is where we come into our second line products like 40-sip bottle, and these are typically 200 milliliter ready-to-drink oral nutritional supplements. They're ideal for patients who can't prepare powdered versions or have other contraindications. This is a nutritionally complete product, meaning it contains a full range of vitamins and minerals, making it suitable as a sole source of nutrition for those who may be particularly reliant on nutrition support. This is suitable for patients who need to meet their basic energy and nutrient requirements and have a preference for milk-based drinks. Again, you should consider here the clinical appropriateness for your patient. Does this meet their nutritional needs? Can they tolerate the 200 milliliters or do they need less? Here, as most of the supplements in this category are milk-based, does your patient have any dietary intolerances or food preferences that should be taken into account? If when asking yourself those questions there are concerns on suitability, we also have alternative supplements. 40 Juice is a high-energy, fat-free, juice-style ONS, and in 200 milliliters it contains 300 calories and 7.8 grams of protein. This is a great choice for patients who can't tolerate the milk-based supplements, either for preference reasons, for being on a low-fat diet, or to help patients with any flavour fatigue they might feel when on nutrition support. We also have 40-sip plant-based, which is a nutritionally complete plant-based supplement providing 300 calories and 12 grams of protein in the 200 milliliters. As it contains plant-based proteins, this may be suitable for patients with dairy or lactose intolerances, or for those patients who prefer a plant-based diet. And third-line products are typically low-volume, high-energy supplements like 40-Sip Compact. In just 125 millilitres, this provides 300 calories and 12 grams of protein, and this is ideal for those patients with fluid restrictions, low tolerance to the second-line products, or other contraindications. An example of a patient that this could be used in is potentially someone living with COPD. Their laboured breathing can mean that they have those increased nutritional requirements, as mentioned earlier, due to their increased energy expenditure. And as a result of any fatigue they may be feeling as a result of this, and through assessing their capacity for compliance with the first or second line products, a compact ready-to-drink product like 40-Sip Compact may be better tolerated. Once you've established what is clinically appropriate and preferred by your patient, you can commence your patient on ONS. Monitoring, as always, is crucial to determine progression against goals and to modify the intervention as necessary. Consider weight, strength, physical appearance, mood, appetite, ability to perform activities of daily living, and compare all of these with the goals originally set. On your review, it's important to check compliance and assess if your treatment outcomes are being achieved. You can make changes as necessary to achieve dietetic goals through trialing different flavours or presentations of M&S. As always, ensure that your care plans or any changes are documented and communicated between care settings. Remember that dietitians are the go-to nutrition experts. If your patient shows no improvement on review or their case is complex, always escalate to your dietetic team as necessary. Following a comprehensive nutritional assessment by a dietitian, they may request a specific product for a patient, and the dietitian's views should always be sought prior to amending the prescription, even if it's not part of the formulary, as multiple factors will have been taken into account when recommending that particular ONS. The need for ONS should be reviewed. ONS should be discontinued when adequate oral intake is established, goals and targets are achieved, and most importantly, when your patient is stable and no longer at risk of malnutrition. Again, at Nutricia, we have a wide needs-based portfolio to suit your patient. Our portfolio suits a wide variety of patient needs and aligns with typical formulary tiers: Complan for first line, 40-Sip bottle and alternatives for second line, and Compact under third line. Although not discussed, our 40-Sip Extra product is a second line alternative with the additional benefit of high protein. The use of this supplement may vary from area to area, so it's important to consult your own local formulary and the clinical judgment of yourself or a prescribing dietitian. Within our portfolio and products, we offer a broad range of flavours that helps to support long-term compliance and positive patient experience. We have more information on our portfolio through resources such as our website and dietetic app, which can help support making the right decision for nutritional support. I'm hoping this session has opened your eyes to the impact of malnutrition, not only to your patient, but to your own clinical practice. And integrating malnutrition screening, particularly with the MUST tool, is straightforward and can be accomplished by following those 3 simple steps. And most often than not, you will have all the information needed to undertake this screening. And do not underestimate the power of a good conversation with your patient. By taking some of those questions we showed earlier, you can tailor your conversation to better your history taking and inform your next steps. And consideration is key. Does your patient fall into a high-risk category? Do they have a clinical history that may affect what's going on inside? Have they expressed changes in their appetite? And are alarm bells ringing as to whether they'd be able to make up their own milkshake? These are all questions to ask yourself that will help you to choose what is best. Above all, have confidence. Whether you're ready to adopt this approach tomorrow or just beginning to explore how to integrate it, Every step you take contributes to ensuring patients receive the right nutritional support at the right time. So thank you for listening into this session.